really important also that we just understand that hypertension is not a disease as such. It is a mechanistic factor. It is a risk factor. And you can see it from a population point of view and an individual point of view. And this talk is about the individual pragmatic treatment in patients with hypertension. So this is the guideline we talked about. It came out last year. Most of you know it. And just to remind you why we're doing this. So what it is and how and why we're doing it. So it's tremendous how much influence you can have on outcomes in the country by just treating hypertension. Heart failure, stroke, CVD death, we all know it. So this is the why, and the rest of the time we'll talk about the how. So to summarize very quickly what is new from 2013 to 2018 in the ESC guideline, you could say it's more aggressive. It's a more aggressive guideline, and we are now starting to see that even from 130/85, we can talk about treating patients if they have a very high risk. We're also starting to say that treating someone with mild hypertension, if the risk is enough, is also fully acceptable. And we're also saying that in the elderly that are fit, that are not frail, it's okay to be aggressive. So more aggressiveness in certain specific populations. The second thing is that things that we already do, combination therapy is now fully a recommendation grade 1. Resistant hypertension should now be done using spironolactone as a fourth agent. And finally, we also know that the device-based therapies that were used, for now at least, are on hold until we find better solutions for that. And of course, the big contention has been this guideline that all of you have heard about, which is the American guideline that came out November the year before, and which all of a sudden claimed that now hypertension is 130/80. And I think the point here is really that it's more of a question of terminology. So when do you call something hypertension and when do you treat it? What the guidelines in the American guidelines are saying is hypertension is from 130. The European guidelines are saying hypertension is 140. But both guidelines are saying when you have a high-risk patient, treat them below 140 in certain cases. So the discrepancies are not as big as they may sound. Of course, the Kenyan guideline is now based on the ESC guideline and follows the conventional categories, and that this makes sense. Young has just alluded to it. 5%, I think it's 3 to 5% of our patients are controlled, so it does not make sense to change that. So, very important to be holistic when we treat these patients, right? So we need to have an holistic approach on our patients. What is a very high-risk patient? What is a high-risk patient? And what is a moderate-risk patient? So the way we treat hyperlipidemia, we look at the patient and we decide, do we want the LDL to be 3, 2.5, or 1.8? It's kind of the same approach we need to do when we treat hypertension. Do we want my patient to be aggressively treated, or do I just want to make it? If it's a frail elderly lady, maybe I want 150. If it's a very sick patient with prior stroke, prior MI, maybe I want to go down to 130. So that's really what this guideline is saying. And of course, the score is at a European score. But again, we know that new data has come out from immigrants, even sub-Saharan African immigrants in Europe, and they've looked at this scale. And what we know is that when you use risk scores in third world countries where CVD is rising, you will underestimate the risk. So they've actually looked at this. So when you use this risk score, this is a risk score for high-risk countries, and you compound it with the correction factor for sub-Saharan Africa, then you have this correction factor for an immigrant from sub-Saharan Africa living in Europe. This is not very far from our middle-class population. It may be our best bet to realize what the real risk is. But as you can see, Southern Asia and sub-Saharan Africa have the highest risk compared to these. Then, of course, we also have to define what is hypertension. What is an office BP? What is an ABPM and a home blood measurement? So it's extremely important to understand when does my patient actually have hypertension. So 135 is not okay for a ABPM. Sorry. Great. And of course, how do you work up our patients? We know this already. It's just important that you're systematic. So you don't want to be working up a patient haphazardly. You really want to make sure you get through everything. So what we try to do, at least in our clinic, is to do a very similar workup for most of our patients, and then we add on. We always have a patient where we haven't done the TSH, and the patient miraculously comes back and asks us, and there is a problem. So try to be systematic. And I think this is basically the minimum that has to be done. So at least a dipstick urine. Remember, dipstick urine can miss proteinuria. So I prefer just to at least do at least a random urine or a UACR. Does it make sense to do a 12-lead ECG? Absolutely. If you see someone with very high pressures with a completely normal ECG, what the first assumption is, obviously, that you're not sure whether this pressure is high all the time. So of course we have masked hypertension, we have white coat hypertension, and we have frank hypertension. And in white coat hypertension, you will often see a very normal ECG. And that's where doing an echo or doing a home BP measurement can be of importance. So when you see ACD changes, I think it's fully warranted to do an echo. And it's even more warranted in our population because we know most of our patients have not had any contact to a physician prior, so we really want to know. So when you do the extra workup, you'll see that echocardiography will be able to help you to see, is this chronic or is this maybe more acute? Other things that can be done, of course, are mentioned here. You can see these in the guidelines. Now, when should we treat? We've discussed it briefly, but the high-risk patients can be treated lower. But of course, we should always start with lifestyle advice. The problem with lifestyle advice is that most of us have a bit of a pessimistic or almost resignation towards treating lifestyle because we know it doesn't work. But it does work. It's just difficult to implement. It's a bit like these guidelines. They're easy to write, but very, very difficult to implement. And the same with lifestyle advice. You can give the advice, but the patient will come back and you'll just watch the weight not changing. But there are some things you can do. What I do is I find a person who is interested and who can implement these things, and I send my patient to that person, and they go through a specific sessions where they go through all the types of lifestyle changes and the behavioral changes that are important: the sleep, the work-life balance, exercise, and so forth. So it's not, you need to have a more holistic approach, and of course it's expensive, but still very, very efficient. I'm sure you saw the study that was done in November 2017 in the JAC, where they used low salt diet and a DASH diet alone to lower blood pressures down up to 20 millimeters of mercury. So these are the BP targets that the guidelines say, and as you can see, it's a recommendation 1. And apart from close monitoring, everything is at very high evidence level. So, what about lifestyle? I've mentioned it. The standards are, as we know it, salt restriction is important. Of course, it's very difficult to measure what is high and low salt restriction, how much is salt restriction. Alcohol is still standing at 8 to 14 units per week. It is still recommended not to avoid binge drinking. And of course, high consumption of fruits, nuts, vegetable, that's a DASH diet. You should control your weight and so forth. These are things that we know, and we know they work when they are implemented. So do we have any evidence for targets? Well, there are 3 big trials, at least. The SPS3 looked at stroke. So stroke, it was found that treating aggressively was not efficient. In the HOPE3 trial, it was also found that the current targets are completely irrelevant. In the ACCORD trial, as you know, which was a kind of a sprint trial on diabetics, it was found that aggressive blood pressure lowering was not efficient. And then the sprint trial was on patients with quite high risk, and with patients with CKD, it was found that being aggressive would work in some patients if they're not frail. So I think that's what has gone into the American guidelines, but of course it's just one trial. So what is the actual evidence for the rest of the guidelines? So the big trials that are used are trials that you all heard about, but I still think it's important to understand that when you talk about 3 millimeters mercury, it's actually significant in these trials. You can see that In the SCOPE trial, we have a systolic blood pressure difference of 3 millimeters mercury and a minus 28% non-fatal stroke benefit. So 3 millimeters mercury is very important. And if you look at now the different drug classes against each other, you again see that even in the absence of very large blood pressure differences, there are some quite important differences in outcome. So what we can see here is that, surprisingly, when you look at all these trials, you'll find that the differences in outcome in the different combinations is less. So what seems to be more important is blood pressure control. So it's more important to control the pressure than to use any drug. But if you look at the closer trials, you'll see that there are some differences that can be made. So here again you see, for instance, in the ALLHAT trial, you found that beta blockers were a bit more efficient, but then in ACCOMPLISH you find the other way around. So the total evidence shows that the differences are minor. I've kind of put everything together in one slide. So this is my own slide, and this is how, kind of a summary of how to look at our patients. So we have 4 or 5 patient types that we can use. We have the uncomplicated patients, which is a large amount of them. Then we have the CAD patients, the CKD patients, the heart and stroke patients. Those are 4 big types of patients that we have. And these are some of the strategies you could use. But as you can see, that these strategies are very, very similar. A here means ACE inhibitor ARB, C means calcium blocker, D means diuretic, and B means beta blocker. And you can see that the combination of these 3 drugs usually end up controlling pressure. And what you do is that when you look at CAD, maybe you upgrade the beta blocker. When you look at CKD, you make sure the patient has an ACE or an ARB. In heart failure, of course, you have a whole different approach that has already been refined. And in atrial fibrillation, of course, you have to be aware that to control a heart rate to a certain specific point is important. In stroke, we have some trials, and you can see that it's preferentially ACE and CC, or ACE or diuretics. But there are some caveats, or there are some problems with this. So one of the problems we have, of course, is accessibility to these drugs. So how do you actually get access to the drugs that you need for the trial? So here are some of this is from the Kenyan guideline, and you can see these are the drugs that we use. And for the long-acting CCBs, we all know that amlodipine is probably superior because of the long half-life. And we can also see that in the thiazide-like and the thiazide diuretics, there's a difference. And in many of the new trials, we are seeing a mix of diuretics being used, but in the trials like the HYVID and some of the more robust trials, it is clothalidone and indapamide that has been used. There's other problems. We've talked about cancer, but that's a whole other story, and I'm not sure whether we believe this story or not. Then, of course, we have ACE inhibitors and beta blockers that are also quite different. And I think it's important to understand that atenolol is a drug that is probably not as well studied. It is well studied, but hasn't had as good outcomes as the other of the beta blockers. And again, labetalol is seen there, but then labetalol, we know, it has a completely different indication, which is pregnancy, and outside pregnancy, it's not a very useful drug for long-term use. So another thing we know is that resistant hypertension is very, very common in Kenya. And I can just show you the stepwise surveys. You can see here that 7.5 to 9.4% of the patients had very, very high blood pressure. And if you look at the middle-aged women, 25% had very high blood pressure. So those are quite different numbers from what you see in others. So what is resistant hypertension? According to this study, which I found really interesting, 80% is pseudo-resistant hypertension. So most of it is non-adherence. So 50% of the 80 is non-adherence, pill counting, electronic monitoring, and so forth. So that's a big chunk of our patients. And we all know this. The patient comes in, we admit them, they start receiving their medication inpatient, and you see the pressure drop quite significantly. Then you have the white coat effect. This is where ABPM is very important. Then, of course, you have your secondary hypertension, which I'm not going to discuss today. It's another very important subset. And then you have your few refractory hypertension. Those are the ones that are actually the resistant hypertension. And those are the ones where we know that spironolactone works. This is another interesting study where they looked at, this is the same population that has been measured by office measurement and then by a measurement that was research-based. And you can see in the research-based measurements, there was actually a bell curve. But in the office measurements, you can see they were quite arbitrary, and obviously you can see that at 130, 140, 150, 160, there are more measurements, which shows that these are manual measurements. Then, when we come to hypertension in blacks, in the guidelines, you have to just remember that the guidelines are based on Afro-Caribbean and American patients. And that has always been the issue until very recently. Now, of course, most of you have shared the Creole trial, and I'm not an investigator. We in fact have an investigator here, so I'm not going to mention it more than just 2 slides. But I think it's impossible to talk about hypertension without mentioning the Creole trial. So 2 years ago, we didn't have any CVD guidelines. We didn't have any local data. And here today, we are discussing our own guidelines, and we're discussing our own randomized trial data. So I can see things are really moving quickly. So just to mention the Creole trial very, very quickly. I'm not going to get into detail, as I said, because we have the investigators here, and I think out of respect, it's not my duty. But I want to just emphasize here is that if you look at the efficacy of these combinations, you can see that perindopril and hydrochlorothiazide was less efficacious at 6 months, and it was more than 3 millimeters. So that is statistically significant, but it's also clinically significant. So that's something we can say for the first time. There is probably good to have a CCB on board. Now, this is a surrogate trial, of course, so we don't know anything about the outcomes. But it's reasonable from what I've just shown you and the other trials to think that there could be a clinical significance. Something else, a bit of a pet peeve of myself, is that it's pretty fantastic to see that we only had 5% of coughs, of dry coughs in perindopril, and 3.7 in amlodipine perindopril. 5.8 and 5. So those are quite low numbers. So 1 in 20 will cough on your perindopril. I think that's pretty impressive data, and I think we need to just understand that it is prudent to try and give an ACE inhibitor if we want to give one. So what are the knowledge gaps we have? We still don't know how to set up proper screening programs. We still don't know what we should do with our many, many young hypertensives. We still don't know what we should do with the pre-hypertensives. What about LVH and proteinuria? Should we treat them significantly different? And what about the optimal salt intake? This is a war that has been going on and has become politicized, but in other parts of the world, salt is really something that can become very political. I still tell my patients to reduce salt, but we really don't know how much they should reduce. And certainly, it's probably wrong to say they should avoid salt. Then also, we need more data on the thiazide-like discussion. And then, of course, now with the Creole trial, the optimal treatment in different groups is starting to be answered. So, I'll just summarize with 10 quick commandments, and that's really just a summary. 10 quick commandments when you treat hypertension. So, you have to know what is hypertension in your clinic, what is hypertension in your office, and what is hypertension when you do the measurements outside. Number 2, you should know how to diagnose and confirm. We see a lot of patients that are erroneously put on blood pressure measurement because of one office measurement. We need to confirm our diagnosis, so you need to screen. And in patients with pre-hypertension, you screen more. Even in patients that are not hypertensive, you screen in 5 years. 3, when to use your drugs. So remember, in grade 1 hypertension below 80 years, you have to start a lifetime intervention, but you can use drugs now in our high-risk patients. And you can also use drugs earlier when the risk is very high. The frail and elderly, be careful. Those are probably the only patients where you should be careful about using 2 drug combinations. And you should also be careful about taking blood pressures lower than 140 in this patient group. 5, how to lower BP. So, well, you have to remember that you have to aim differently at different patients. So you do not aim lower than 120. You aim 130 in high risk and 140 in the frail or the low risk. And finally, of course, not finally, number 6 is a lifestyle intervention. We all know it: sodium restriction, alcohol moderation, healthy eating. Set up an infrastructure in your clinic to make sure these are addressed. If you don't address them, it's like you just let the cooker boil and you're just trying to put a lid on the cooker. You need to address these. And number 7, combination therapy. I think we're almost ahead actually on this. I think Kenya generally is ahead on using combination therapy. I don't know whether it's industry driven. I think combination therapy is prudent in most of our patients. And then number 8, the single pill strategy. Adherence is so important. And 9, it's important that you will use the RAS, CCB, and thiazide-like, but the beta blockers can also be used. And especially in angina, post-MI, heart failure, especially in heart failure also, and in your patient with a high heart rate. Those could be smokers, those could be patients with high BMI. And finally, and probably most importantly, you have to treat the whole patient. So does the patient have a need for aspirin? Does my patient have a need for a statin? Does my patient have a need for special intervention? So treat the whole patient and make sure everything else around the patient is treated. So I said at the beginning there's no such disease as hypertension. It's just a mechanistic risk factor. But now I'd say from the individual standpoint, you have to look at the overall risk assessment, the global risk assessment of the patient. Then you have to look at the individual risk factors, the benefit of each drug and the drawbacks of each drug. And then of course finally you have to ask the patient, are you willing to take my drugs? And if he says yes, go ahead, then at least you have something. So I think that's enough for now. Thank you.
Emma Karari. I'm a bit concerned about journalism in this country. You had alluded to the issue of HCTZ. There have been articles on ARBs. And I don't think really they sought any information from the medical team, but they just went out, published articles, and I'm sure some of you, at least I was one of them, and I know quite a number of you probably got panic messages from patients who are on treatment, and I guess they're still ongoing. These new guidelines which we have just released actually indicate we should be using HCTZ, indicate we should be using these drugs. I'm not convinced, but some study done, I think in Sweden, relating HCTZ to skin cancer is something that really should apply here. I think we need to discuss this issue, but I also feel like as a specialist, we need to find a way of making a response in the media so that we have the correct information outside. That's my point.
Thank you very much. I'm Joseph from American. I just wanted to thank all the speakers for their talks, but just in relation to hypertension targets, I mean, in certain specific situations, sometimes you do end up aiming for a slightly lower blood pressure. So, for example, in somebody with microbleeds, cerebral amyloid angiopathy, sometimes you try and push the blood pressure down a little bit just to reduce the risk of getting a bleed. It's not entirely evidence-based, but I think there is some suggestion that may be useful.
Thank you, Dr. Yosa from Mombasa, Boma Hospital at Kakantu. One comment, our home, Sub-Saharan, is home of HIV/AIDS, and it couldn't sit well. But I think DVT and primary embolism is so high also in them because of protein C or S deficiencies. My question goes to the last speaker. I like this slide, the comment on routine tests, dipsticks and protein and so. Why is that so unpopular in most clinics, use of the dipsticks?
Resistant hypertension, those who are of more than 3 antihypertensives, still we are not able to attain the target of blood pressure. So what are the 4th agent we'll add and how to monitor them?
My name is Dr. Getura, President of the Kenya Cardiac Society. I think I would just like to respond to what Dr. Karade said. I think these are a very important opportunity for us to discuss this matter because of course our patients are very much online and they are reading internet, and therefore these adversaries are causing a lot of alarm. So as Kenya Cardiac Society, we of course have been tasked by the Ministry of Health to coordinate a technical working group for cardiovascular disease as part of the NCD working forum. So the Ministry of Health, together with the Kenya Cardiac Society, we have already formed a committee together with the medical board and the pharmacy and poison board. And actually Professor Ogola, Dai, and other people are involved in this committee. We have met once, and we have gone through, we have actually started to look at that advisory. Of course, I know, as Karade said, the medical board, the pharmacy and poison board, when they released this advisory, they did not consult the physician, but they say their work is to, any information which is out there, they would rather release it, so that because they work on being precautionary. So otherwise, from the discussion, we have reviewed that issue of the HTZ. We have also looked at what the international world is looking at, and I think for now, the ministry is going to respond. There is that document to be released, both for the patients and for the clinicians. But just for this meeting, I think the overall feeling for all of us is that we should continue. We are going to continue using HTZ. It's not going to be withdrawn. We feel that data, observational study from Europe, it's not strong enough to warrant withdrawal of this drug, and it's a very important drug. So I think the minister is yet to release that document. Of course, it has to undergo a lot of discussion, so we should continue. On the idea of the ACE inhibitor, ARB, again, we have also started that discussion, but again, for that, for the ACE and the ARB, it is quite clear the drugs which have a problem are those which are manufactured in certain sites, because of contamination. It's not the ARB or the ACE which is bad, but the contaminant of the manufacturers. And therefore, both international, they're actually withdrawing drugs from certain, which were made from certain factories. Unfortunately, in Kenya here, we have a lot of blood, and therefore one of the challenges, and we have told the medical board, they need to identify it, and they need to do this early to know all these many products that we are getting, especially the generics. Do we know where they are being manufactured? So again, the Pharmacy and Poison Board it's looking at all those different agents, and therefore, so they can also release which are some of the drugs that need to be withdrawn. So I think for me, just to give a reassurance, we should continue using HTZ. The ACE and ARBs are equal, they are good, but it is those which were made from certain factories. But of course, it's a big challenge because we know the Pharmacy and Poison Board, who are supposed to regulate bringing these drugs, they need to be very sure of where these drugs are coming from. Thank you very much. That's my comment.
Dr. Anders, specific concern from Dr. Hooker on do we really, are the targets too tight? Because we know even moderate changes in blood pressure have enormous benefits. In a local situation where we have only 4% people actually in control, with 140/90 as the target, are we being too ambitious? And Yosa is wondering why we don't use proteinuria as often as we should in evaluation of hypertension, amongst the other questions.
Yes, yeah. Let me start with can I just make a very short comment on the HCTZ? It's a Danish study, and I've read it in detail, and it's a very, very large population study, and as you know, those associations in a population that has very light skin, as we know, and that has squamous cell carcinoma. So I think it's close to irrelevant to our population, to be honest. The second is about the low BP. So this is a guideline. And luckily, guidelines only guide you, but they don't tell you what to do. They just tell you, look at, this is what you should do, generally speaking. But of course, as a specialist, you can do whatever you want to do. So if you have a patient with an aortic aneurysm, you're not going to go for 140. You're going to go for 125. If you have a patient with Marfan syndrome, you're going to make sure that patient is well controlled. In heart failure, I go way lower because I know the heart doesn't like 140 because it's very weak. The EF is 20 or 15. It wants much lower pressures. So I totally agree with you. You have to individualize that treatment. So, but we need to have guidelines. We need to tell people what to do on a general basis. I totally buy the idea of treating risk instead of treating numbers. So I think definitely whenever your patient has high risk, treat them down to what you think is feasible. But I'm also, I really believe in outpatient blood pressure monitoring. And these days I actually never put anyone on drugs on an office pressure, ever. If I have very high pressures, I do it maybe to get them out of trouble, but that's it. I'll still monitor them. I want a good number of pressures before I draw any conclusions. And it's very surprising what the pressures actually tell you when they come back and show you the pressures. They're often much, much lower than you think. As for the dipstick, dipstick is, I think that's a sin being, that it's done everywhere across the world. But I think particularly in our setting, with a lot of GN, a lot of active urine, a lot of proteinuria, a lot of poorly controlled hypertension, a dipstick is really, really important. And why people don't do it, I guess we need to emphasize it in the guidelines, but it's extremely important in our hypertension patients. Someone asked about the fourth drug, and remember we have the pathway trial, so we actually know that we should start with number 4 should be spironolactone, but we can also use a beta blocker or alpha, but spironolactone was one of the far best effect, and the reason is that these people often have low renin hypertension, so they have low renin levels, so when you give spironolactone, it works better. And the other thing I have to say about HTZ is that we're using 12.5 is probably a suboptimal dose. And that is why I say use indapamide, use clofazimine. I think there was just one thing I wanted to mention about the non-valvular. I know it's not an area, but just remember that in some of the trials there were actually patients with valvular atrial fibrillation. Some study of the big trials had valvular disease. And if you look at the patients with mild MS, mild AS, those ones can still be treated with the DOA, mild. So mild MS.